All right, today we're jumping into a topic called ascites. Now, that name might not ring a bell, but it is the single most common complication of advanced liver disease. And more importantly, it's a critical turning point for patients. So let's get into what it is and why it matters so much.
So on the surface, the definition is super simple. Ascites is when fluid builds up where it shouldn't be, inside your abdomen, in a space called the peritoneal cavity. But you know that simple sentence? It hides a really complex and serious problem going on inside the body.
Okay, so that leads to the big question, right? Where is all this fluid coming from, and why is it just pooling in the abdomen? To get to the bottom of that, we have to take a close look at the liver.
So let's dig in and figure out the root cause here. This isn't some random thing happening. It's a direct signal that one of the body's most important organs is in serious trouble.
Yeah, the story of ascites pretty much always starts with something called cirrhosis. This is what happens when the liver gets so scarred up and damaged that it just can't do its job anymore. Imagine all that healthy, soft liver tissue being replaced by tough, useless scar tissue.
And all that scarring? It creates a massive plumbing problem in your body. Think of your liver like a filter. Well, when it gets all clogged up with scar tissue, blood can't flow through it like it's supposed to. So what happens? The pressure backs up, big time. It builds up in the main vein that feeds the liver. That's the portal vein. And this crazy pressure, called portal hypertension, literally forces fluid to leak right out of the blood vessels and into the belly.
And look, this isn't some rare, obscure cause. It's the main cause. In Western countries, something like 75% of all ascites cases come directly from cirrhosis, causing this insane pressure backup. It's the #1 reason, by a long shot.
Okay, so a doctor sees the swollen abdomen, they suspect what's going on, but how do they know for sure? Well, they go straight to the source. They investigate the fluid itself.
And the way they do that is with a procedure called a paracentesis. It sounds complicated, but really, they insert a needle into the abdomen to draw out a sample of that fluid. And they're not just doing this to drain it, not yet anyway, they're doing it to analyze it. That fluid is holding all the clues.
And the absolute key to cracking this case is this really clever test called the serum ascites albumin gradient, or SAAG for short. It's basically a pressure check. They compare the protein levels in your blood to the levels in that abdominal fluid. If there's a big difference, a high SAG, it points straight to that high-pressure plumbing problem we were talking about, with something like 97% accuracy. On the flip side, a low SAG suggests the fluid is leaking for a different reason, maybe an infection or even a malignancy.
But they're not just looking at the SAG. That fluid analysis tells them a few other critical things. For example, a really low protein level in the fluid. That's a huge red flag because it means that fluid is the perfect breeding ground for bacteria. And if they see a high count of neutrophils, those are a type of white blood cell. That tells them an infection isn't just a risk, it's already happening.
All right, so once they've confirmed the diagnosis, it's time for treatment. But this isn't a one-size-fits-all kind of deal. The game plan is completely tailored to just how severe the ascites is.
Yeah, they actually grade it. Grade 1 is so mild you can only see it on an ultrasound, and you don't even need treatment for it. Grade 2 is when you start to see that moderate visible swelling. That's managed with a low-salt diet and diuretics, water pills. But then you have grade 3. This is when the abdomen is really large and tight with fluid, and the approach has to get much, much more aggressive.
So for that middle-of-the-road grade 2 ascites, using diuretics is a really careful balancing act. Doctors don't just, throw a bunch of pills at the patient. They're very methodical. They'll start with one kind of diuretic, something like spironolactone, and they'll slowly ramp up the dose. If that's still not cutting it, then they'll add a second, more powerful one like furosemide. It's all about going slow and steady to avoid shocking the system.
And here's the thing. Diuretics work, but they are absolutely a double-edged sword. I mean, pushing all that fluid out can put a huge strain on the kidneys, it can mess up your body's critical electrolyte balance, and it can even make something called hepatic encephalopathy. That's a type of brain fog from liver failure even worse. This is exactly why patients on these meds have to be monitored so closely.
But what about when it's not moderate, when the fluid buildup is just massive? When you're in that grade 3 category? Well, diuretics often aren't enough, or they're just too slow to give any real relief. And that's when you have to take a much more direct approach.
And in fact, the clinical guidelines are super clear about this. For severe ascites, the first thing you do is a large volume paracentesis, or LVP. Now, this is the same needle procedure they used for the diagnosis, but instead of just taking a little sample, they're draining liters and liters of fluid. It gives immediate relief and, as the guidelines put it, it's more effective than diuretics and significantly shortens the duration of hospital stay. It's a game changer.
But you can't just pull that much fluid out of someone's body and call it a day. Think about it. That can cause a really dangerous drop in blood pressure. Your whole circulatory system can go into shock. So to prevent that, patients get an IV drip of albumin. That's a protein that basically helps keep fluid inside the blood vessels where it belongs. And this one step is huge. It's been shown to cut down on complications, and most importantly, it reduces mortality.
But even with these powerful treatments, managing ascites is just a constant uphill battle, because the condition itself just opens the door to a whole host of other really dangerous and sometimes life-threatening problems. Probably the most feared complication is something called spontaneous bacterial peritonitis, or SPP. Remember how we said that acidic fluid is the perfect breeding ground for bacteria? Well, SPP is what happens when that fluid actually gets infected. And it is an incredibly serious emergency that needs antibiotics, like right now.
So how do they know it's SBP? They go right back to that fluid analysis. If they see a count of more than 250 neutrophils per cubic millimeter in that fluid, that's the smoking gun. It's a clear signal that the body's immune cells are flooding the area to fight off a major infection.
And it's not just infection. There are other huge hurdles. Sometimes the ascites becomes refractory, which is just a fancy way of saying it stops responding to the diuretics completely. And then, in the absolute worst cases, patients can develop something called hepatorenal syndrome. And that is just devastating. It's when the failing liver actually causes the kidneys to start shutting down too.
And all of this brings us to our final and maybe the most critical point of all. You see, ascites isn't just a symptom you manage. It's a massive signpost. It's the body telling you that the underlying liver disease has hit a very, very advanced and dangerous stage.
And the prognosis? It's grim. When ascites shows up, the mortality rate is about 50% within 2 years. 50%. Its appearance is a clear signal to everyone, doctors and patients, that the game has completely changed. You need a new strategy.
So that leaves us with this final crucial question. If managing ascites with diuretics and drainage procedures is really just a temporary fix for a problem with such a tough prognosis, what's the real path forward? What's the ultimate solution? Well, for patients who are eligible, the answer is a liver transplant. All these other treatments we've talked about, they're essentially a bridge. They're designed to keep the patient as stable as possible until the real problem, that failing liver, can finally be replaced.